I'm Dr. Michael Zemenides, and welcome to Beyond the Results, a podcast where we look past blood tests and scans to understand what's really going on with your health. In today's episode, we're focusing on alcohol and the liver, an area where damage often begins long before results turn abnormal. I'm joined by Dr. Arjuna Singanayagam, a consultant hepatologist and regional advisor for the Medical Council on Alcohol. Dr. Singanayagam works at the front line of alcohol-related liver disease, and he sees every day the gap between what people think is normal drinking and the reality of its impact on the body. Together, we'll be talking about how alcohol affects the liver long before symptoms appear, the early warning signs people often miss, and why relying solely on blood tests can give a false sense of reassurance.
My name's Dr. Michael Zemenides. I'm one of the co-founders of BAC General Practice, and this is...
I'm Dr. Arjuna Singanayagam. I'm a senior lecturer in hepatology and consultant hepatologist at City St George's University and St George's Hospital, NHS Trust, respectively.
And important for today, you are also
A regional advisor for the Medical Council on Alcohol.
Yeah. Which is kind of weird because we went to medical school together, so we've known each other 25 years.
Yeah.
And we lived together for 3 years.
Yeah.
And I was probably quite a big instigator in dragging you out.
There you were.
So it's interesting when we talk about how liver can affect the body. It's weird when you're thinking about it as a professional now, considering how you might have been as just normal teenagers or normal 20-year-olds at university. And we kind of had a brief discussion while we were prepping about binge drinking and what categorizes as like when you reach binge levels.
Yeah. I mean, when we think back to what people were drinking at university,
Yeah.
they were large quantities of alcohol, large quantities. And a binge drink is classified now as more than 6 units in a short period of time. 6 units is what? Couple of beers, couple of pints of beers,
2.5 pints, basically.
or six shots, right? And the thing that people were doing back in university days is multiple brands of shots. So everyone was binge drinking then.
Yeah.
Times have changed, I think, now. You know, having seen the university students, spoken to university students now.
Yeah.
But the amount that was being drunk in those days was heavy. Yeah, and it was definitely binge drinking.
I mean, we had an event every Saturday called Fives at one of the student unions where you could buy 5 pints of beer in a jug for £5. And that was something that sports teams used to do quite regularly on the weekend. Now, when you look back at those kind of practices, you realize how unhealthy they were.
Yeah, big time.
It's interesting when you're adults in a professional setting, when you think about, and you can imagine that if we had continued that kind of behavior into later life, how you would have just thought of it as normal.
Yeah.
And that can be one of the significant challenges when you're dealing with people who have been drinking.
Yeah, and normalization of the alcohol
Yeah.
intake. You know, it's just part of what I do. It's just part of the culture of, you know, going to work and after work, going to have a drink with your mates. And we drink, this is how much we normally drink. And my friend's not got problems, you know, so why have I got problems?
Yeah.
That is a common thing that we hear in consultations.
All right. So why don't we kind of start with like what the liver actually does?
Yeah. So needless to say, I'm passionate about the liver. It's my field. And it's reported to have over 500 functions. Okay. So I probably can't concisely tell you what the liver does. But I guess the crucial thing that we are here to talk about is that it processes alcohol. Alcohol is a toxic substance. Any form of alcohol is toxic to the liver. When you're drinking alcohol, the liver prioritizes getting rid of that toxin so it can't damage your body.
Yeah.
And it does that by various enzymes within the liver. It converts alcohol to another intermediate substance called acetaldehyde, which is even more toxic than alcohol. And then the next step is actually nullifying it and getting rid of those metabolized substances in the urine and various other ways. So one of the primary functions is to detoxify the body. It's the kind of power plant in detoxifying the whole body from a variety of different toxins.
And we mentioned before that often people get confused between the only alcohol can affect the liver, but there is non-alcoholic fatty liver disease as well.
Yeah, so non-alcoholic fatty liver disease, which has recently termed, okay, there's a new term, which is a mouthful. It's called metabolic dysfunction associated steatotic liver disease. But that basically means fatty liver disease that is not caused by alcohol. It's caused by a component of the metabolic syndrome.
Okay.
And the metabolic syndrome, some people would have heard of that, but metabolic syndrome is basically a constellation of different conditions that can increase your risk of heart disease, strokes, etc. And in that metabolic syndrome, you've got high blood pressure, you've got high cholesterol, diabetes, fatty liver as part of it, various other conditions. So basically, non-alcoholic fatty liver disease has now been rebadged as fatty liver due to having one of those components of the metabolic syndrome.
So no, that can be quite confusing because we do get patients who get diagnosed with a fatty liver and they're very confused because they either don't drink any alcohol at all or what they class as minimal amounts.
Yeah, so this is a classic thing I hear.
Yeah.
Is patient comes in, has fatty liver, you say, you've got fatty liver. Oh, that's really strange. I don't drink. And this is a huge misconception that all liver disease is caused by alcohol, which is not correct. Globally, the leading cause now is non-alcoholic fatty liver disease or metabolic dysfunction associated fatty liver disease.
So often as GPs, we pick up the fatty liver incidentally on an ultrasound usually, and then we have to do a scoring system which basically grades you into how likely you are for that fatty liver to have like a negative effect in the future or causing fibrosis.
Yeah.
And we do things like FIB4 or ELF tests to kind of give a patient that indication. And then I guess you see the ones that we flag up as high risk and then we'll refer them on to the specialty.
Yeah.
Yeah. So that's normally the process of how things go.
So I think you mentioned there fibrosis and various other things. So I think it's important for people to know that there is a spectrum between normal liver and at the end of that is cirrhosis. Cirrhosis means extensive scarring or damage to the liver, and that is caused by repeated injury. And the liver adapts to that repeated injury. And in this case, we're talking about alcohol. So alcohol is repeatedly causing injury and inflammation to the liver. The liver accumulates fat in that process. And if you're doing that consistently, the liver adapts to that by saying, hey, I don't want to be inflamed anymore. So what I'm going to do is I'm going to put dead wood down in my liver. I'm going to put scar tissue down. And that dead wood or scar tissue can't be inflamed. And over the course of years, if that scar tissue builds and builds and builds and builds, you could end up with cirrhosis, where most of your liver contains scar tissue. And the downside to that is that scar tissue hasn't got function. It's not like normal liver. So we talk about the 500 functions of the liver. If most of your liver is scarred up and you've got 10, 20% remaining, you're on a knife edge, because if that process continues, you can function with a very little amount of your liver. But if that process continues, you're going to develop liver failure, which is where you haven't got enough normal liver. Okay. And the people that are predisposed to that are people that have cirrhosis. Okay. But that is the end of the spectrum. Even people that are getting early stages of that, so scarring or fibrosis, they are more likely to lead to that. So it's basically that spectrum, and that's identifying where on that spectrum. So you mentioned various other tests that we can do, like the FIB4 index, which is based on blood tests. It's a calculated tool that can predict to reasonably good accuracy how much scar tissue you have in your liver. And that's usually the first line. And then you can do other biomarker tests that are based on blood tests that then increase your accuracy of working out what your likelihood is of having significant scarring. And that's what we want to do now. The liver disease community is now doing, as most specialties do, is going into the community and trying to prevent and identifying diseases at earlier stages. And the tools that you mentioned about identifying people at earlier stages of scarring so that they don't end up with cirrhosis, because largely speaking, if you develop cirrhosis, that is irreversible. Whereas if you have fat or a little bit of inflammation in your liver and some scarring in your liver, that is easily reversible and preventable. So we want to try and capture those people.
Lots of people don't think they're heavy drinkers. So one of the questions you might get is how much alcohol is too much for the liver?
So the honest answer, Mike, is that no amount of alcohol is safe for the liver. And when people say heavy drinker, everyone has a different perspective on that. And everyone's bodies are different. So how you metabolize alcohol can be completely different from one person to the next. There are so many different factors: age, gender, body composition, genetics, all loads of different things. So being a heavy drinker for one person is different to the other. And the truth is that any alcohol is toxic. The liver doesn't treat the type of alcohol you drink. All alcohol is toxic. So the recommendations from the UK government are 14 units per week. That's blanket across men and women. And that is really it is arbitrary, but it's considered a level that reduces risk. It's not a safe level. It's just a level based on a population that reduces the risk of significant harm.
Okay. And that's the thing that always shocked me, because I'm typically someone who I used to drink once, like every time I went out, or what I'd call like a big night.
Yeah.
So I'd have more consumption on those nights, but not be kind of teetotal in between. But I had one of my girlfriends used to like to have a glass of wine with every meal. And to keep her company, I started drinking a glass. And then I realized, like after a few months, that it's really, really easy to get to that 14 units a week just by having a glass of wine a night.
Yeah.
And then if you think about, if you add that night on at the end of the week, you can go way over that 14
So
units.
that's
very, very simple.
That's really common.
Yeah.
So a lot of people in my clinic are drinking a glass of wine or 2 glasses of wine a night, just habitually, and then they'll go out every weekend. And this is the biggest thing that surprises patients in the clinic is when you tell them you've got cirrhosis, they are really shocked and surprised because they think you might get symptoms from that, which you usually don't. It's often a symptom-free disease until you're at the very end stage of it. And the other thing is they think, well, I'm doing it, so is everyone else. Why is this happening and what's caused this? And it is the alcohol that's caused it. And it's just the lack of awareness of the damage that the alcohol is doing, the regular drinking and then the superimposed going out drinking as well. And you're right, that's the kind of number one thing I'd say that patients are surprised by is how has my alcohol consumption led to this? And it's a lack of awareness of the quantity they're drinking. And also they're not having alcohol-free days. It's just becoming more habitual. It's just kind of becoming their routine.
It's very, very tricky because obviously what we get in the GP setting is that they get very non-specific symptoms like maybe a little bit of bloating or a little bit of fatigue, and trying to get them to correlate those with their alcohol consumption is incredibly difficult because I've been doing this for years. Why would it suddenly be giving me a problem now? And I can imagine that problem's even greater when they end up in your clinic. But at least when a specialist tells them, they think, oh, this is like the proper person who's telling me rather than, oh, it's just a GP.
Sure. And we have tools to try and quantify the damage that it's doing to the organs. So you're right. And the thing is, that people don't realize that alcohol it's a psychoactive drug. And it has cumulative effects. So it is really important that people recognize that and take stock and really think to themselves, is the amount I'm drinking safe? Is it going to cause me harm?
Right. So would you say that there are any particular factors that make you more prone to having alcohol-related liver disease if you're drinking alcohol?
Again, it's difficult to say because it is going to be multifactorial. So again, genetics has a role.
But simple things like, for example, like body weight and so on, like whether the alcohol would have an effect.
Yeah, so there is a concept of metabolic syndrome with alcohol now. So what we know is that if you drink even moderate quantities of alcohol, but you have a component of the metabolic syndrome, particularly obesity and type 2 diabetes, they are going to be synergistic and damaging your liver. So, we mentioned non-alcoholic fatty liver disease and the new terminology. That in its own right can cause liver damage and cirrhosis. And if you add moderate quantities of alcohol, let alone heavy alcohol drinking to that, synergistically, that is going to cause more damage than if you just had obesity or type 2 diabetes on its own. So that's a key factor because, again, people think, I'm not drinking that much, but if they've got obesity and they've got type 2 diabetes, those things are going to combine and cause more liver damage than if they weren't both there.
And what's the most shocking thing when people first come to your clinic, when they've been referred specifically for liver-related issues? And what's the most common reaction that you get that you're not expecting from patients?
It is a shock that whatever they're drinking has led to this. And there is often a belief that just because they're drinking with others and they're drinking the same quantities, why is it me? Why not that person? Surely we're both drinking the same.
So I always get the whole, my mates will drink far more than I do. Fine. Is that kind of what you're hearing?
Absolutely.
Okay.
Absolutely. But like I say, you're an individual. We have this concept of personalized medicine. Just because your friend is drinking double the amount you do, maybe they've got more enzymes to metabolize the alcohol than you do. We're not going to know at that level, but the point is you are an individual, and you've got to, if someone is telling you whatever you're doing is harming your liver, then you've got to think.
And I always tell patients that it's a cumulative effect. And the problem is that when you're symptomatic very, very late on in the disease, but you're doing that harm over multiple years or decades, it's that whole I'm fine, so there's nothing wrong with what I'm doing because I'm currently fine. But the problem is that when they end up in cirrhosis, that's almost past the point of no return. And that's the tricky bit. Have you had any tips or tricks that you tell patients about how they might be able to reduce their alcohol intake? Because they want to go out to the pub with their regular group of friends. I've tried to convince people to do like half and halves. Like we'll do basically shandies. We'll have half a pint with beer with the rest with, I guess, lemonade or tonic or whatever they put in it. And that way they still feel like they're keeping up and they're having the same volume, but it's effectively having half the amount of alcohol.
Yeah.
Is there any kind of those kind of strategies that you might recommend?
There's a lot of strategies, and I have to be honest, I don't specifically go into the details on how to do that, because there are lots of community support, alcohol support services that will help you do that.
Yeah.
And I would say, if you think you have a problem with drinking, you should engage with the community alcohol support service really early on. And I think one of the biggest barriers to doing that is stigma. That people think, if people know that I'm going to this support service, the people will label me as an alcoholic. But actually, that's just not true at all. People that, from all walks of life, all ages, drink too much alcohol. And early engagement should normalize this. And so I think it's really important, and they will give you good strategies. So, doing that kind of thing, half and half, they can help. My message has to be, if you're drinking harmful quantities of alcohol, you should stop. Because those people that are drinking harmful quantities of alcohol are putting themselves at risk. And there is a high risk of relapse unless that message gets through. But yes, you're right. There are different strategies to achieve that. And if you're drinking harmful quantities of alcohol, and that's considered more than 35 units per week in a female, and more than 50 in a male, then you should taper that gradually. You shouldn't abruptly stop, because there's a risk of withdrawal symptoms.
We had a little bit of a chat about this when we were preparing for this, but I remember actually asking you why you picked hepatology specifically as a specialty. I mean, what was it for you that made you think, actually, this is what I want to get into. This is what I want to dedicate my life to?
I'd say it's multiple reasons. And obviously, when you start off doing something, your reasons change over time. And when I started off, I just thought, this is an interesting organ. It's a great organ. I saw people with end-stage liver disease, and you can get a lot of complications from that. And I saw that there were procedures involved. So medical procedures you could do, like endoscopy, to try and control bleeding, for example, into the gut, which you can get as a complication of advanced liver disease. Those are the things that interested me at that stage. But as I've progressed through my career, I have to say one of the things that really draws me into it is alcohol and the effect of alcohol on the liver. And a lot of the people who I see in my clinic have just been through really hard times. They suffer from depression, anxiety, and they use alcohol as a coping mechanism. And actually being able to support people through reduction of alcohol and into abstinence and seeing the benefits, a lot of people that achieve that abstinence come and tell me, like, I've got a new lease of life. I can sleep better. I'm saving money. So many different benefits, and actually seeing that process is fantastic. It's actually very rewarding. And patients are so grateful. So that is one of the biggest draws to the career I've picked.
It's such a classical idea of how we pick specialties when we're younger versions of ourselves. I think that idea of, I love the topic, or I love the kind of the physiology or the medicine behind a particular field. And then you make this decision about, do I want to be, they label you as like you're a surgeon or a medic. But often you end up trying to find that balance of what you like. So for some people it's teaching, some people it's academic, some people it's a combination of clinics where you see patients regularly versus procedures. And if you're very procedure led, then you end up in those kind of specialties. So I guess what you're saying is that it's quite a balance. Initially it was you love the topic. It's quite a balance that you're doing bits with your hands, you're also seeing patients, and you kind of fell in love with the people that you're treating.
Absolutely.
That's really good. You said you did your elective in Australia.
I did my elective in Australia in the Prince of Wales Hospital in Sydney in liver disease. And again, I had a great time and saw some really interesting pathology. And I think this really spurred on my decision to continue in liver disease and make that my career.
And I got lots of phone calls and messages with you with an Australian accent, which I greatly appreciated at the time.
I've got half my family live in Australia, and I do love the Aussie accent, I used to watch a lot of Neighbours and Home and Away back in the day.
Didn't we all? So let's talk a little bit about alcohol and the psychology behind why people drink.
Obviously, people drink for a variety of different reasons. Some, it is to do with their upbringing. So a lot of heavy drinkers have had a parent or sibling, what we would call an alcohol-centric family. So alcohol is the focus in their family. And they will say that, when we talk to them about alcohol. But of course, alcohol goes hand in hand with difficulties with mental health. So people with depression, anxiety, and in essence, for some people, alcohol is a coping mechanism. Not very good one, but it is a coping mechanism. I've got patients who use it for insomnia, but again, what's the driver for the insomnia? So heavy alcohol consumption, not always, but often has an underlying psychological reasons to why they are using alcohol as a coping mechanism. And part of our consultations and exploration as to the drivers to drink is establishing what those particularly are and how we can tackle those.
Yeah, because it's quite interesting that from a GP point of view, one of the early triggers that we realize, or that we ask people to try and keep track of, is if they're self-medicating effectively. So one of the first warning signs that your stress levels or your mood might be dipping is that you're starting to drink slightly more, or you're starting to smoke slightly more if you're a smoker. And you might not notice any of the other symptoms. So we always try and get people to understand that, if they're starting to go from that 1 drink a night to 2 drinks or 3 drinks, that's one of those soft signs that their mental health might be suffering, and maybe do something constructive rather than turn to alcohol to
absolutely totally agree. So self-awareness and delving into yourself, what is motivating you to do this, is so important.
Insight is so difficult, though. It's very, very difficult.
It is, and it's difficult, and therefore the easier route is just to blunt yourself on it and drink alcohol. But it's so important, because if you don't recognize that, it's just it can be a slippery slope.
So obviously we've spoken about the services that are available to helping people with alcohol dependence. And obviously every area has a slightly different name for it, but it's essentially the drugs and alcohol service. And every local GP would have access to that service, but you don't have to be referred by a GP. You can refer yourself. And these are all available online. So if you just put in drugs and alcohol into any Google search with your postcode, the relevant service for your area will come up. And so even if you're worried about interacting with a GP about them knowing that you might be drinking, don't worry about it. You can just go straight to the service.
Absolutely. It's all self-referral.
And also they do have things where they will give you access to talking therapy or mental health support, as well as just specifically that it's not just about the alcohol, it's about supporting you as a whole.
Absolutely right. Just alcohol prevention or reduction is not the end story. It's holistic. It's about dealing with the drivers to drink.
So why don't we track a few of the myths that revolve around alcohol? So one of the things that we tend to get is something better than another thing. So is wine better than beer, for example?
Yeah, and again, this is a common misconception that patients have. They say, well, I've cut spirits just drinking beer, so it's okay. Sadly, it's not okay. Alcohol is alcohol. The liver doesn't know the difference between the taste of your alcohol. It just knows that the alcohol is toxic. So any form of alcohol is not good for your liver. So whilst people might think cutting out spirits, they've made progress, and if they feel they've made progress, then great. But it's actually the quantity of alcohol that you need to be reducing, and the pattern of drinking, and the psychological aspects, the craving of alcohol, the ability to be able to be free from alcohol for a few days a week or a month, for example, in dry January. So I think those are the key things.
Yeah, because I think we mentioned about whether time between drinking days is of benefit. And obviously you might rest the liver for a day. That helps in a way because it breaks the psychological dependence, but it's actually the unit quantity over the week that's the most significant thing that affects the liver.
I think the unit quantity makes a difference, but I do think it's also important to have alcohol-free days, because as you say, it does rest the liver and it breaks that cycle of psychological dependence and normalization of alcohol. This is the problem. If your alcohol is being drunk throughout the week, it becomes habitual and normalized, and that then can lead to further drinking or cumulative effect.
And I had one of my Brazilian friends recently ask me, why do you do dry January? We don't have this thing in Brazil. And I think the best thing that I could come up with, other than the health benefits of doing it, is that if you can prove to an individual that they don't need alcohol for a month, then actually that's the first step to showing them that you don't actually need alcohol at all.
Full stop.
Yeah. So I think that's the most impactful thing for dry January that I can think of to answer this person.
Yeah.
But is there another way that you would kind of tackle that? Or is that?
Yeah, I think that's right. It's about demonstrating you're not psychologically dependent on something to yourself.
You mentioned things that people might say to you is that like, oh, I drink, but I do something else that makes it better. So like, for example, one of the things is like, oh, I live a really clean life, but I have a little bit of a drink. Do you think like exercise can balance out the amount of alcohol you drink?
The answer is no. Again, the alcohol is toxic to the liver. It doesn't matter whether you're a marathon runner or a couch potato. Alcohol is toxic to your liver. Obviously, it's good to have a healthy lifestyle. And we spoke about before the combination of metabolic syndrome and drinking alcohol together has synergistic effects and bad effects on the liver. So if you're going to be exercising a lot and you're going to reduce those components of the metabolic syndrome, you're going to be less likely to have a heavier weight, more likely to have a healthier weight. So those things do matter.
Yeah.
But I don't think you can drink, 5 pints of beer in a day and say, well, it's okay because I go to the gym every day. The liver doesn't distinguish between someone that goes to the gym or not in terms of the impact of alcohol on it.
And also like the amount of calories in alcoholic drinks in general tends to be quite high. Like I tend to think of each alcoholic drink as having like a chocolate bar. So if you're drinking 5 or 6 pints of beer, or you're having shots with like something sugary on the side, it's quite difficult to overcome that kind of calorie intake with alcohol.
But I think the key thing is that these are what we call empty calories. So they are calorific. They are not good for you. When the liver is trying to prioritize detoxifying the body, it's not dealing with sugar control very well. It's not dealing with fat metabolism very well. And it fills you up. So you're not then eating large quantities of healthy nutritional food. So this is why people that drink heavily, they can be quite low in certain other vitamins, some of the vitamin B vitamins, for example, thiamine, for example. And these are crucial vitamins, and there are complications to having low levels of those vitamins. And it's all as a consequence of drinking large quantities of alcohol, which then fills you up, empty calories, and you're not eating normal three or plus meals a day that is of actual nutritional benefit.
Do young people tend to tell you, well, I'm fine because I'm young?
I think young people are surprised that if they're in the clinic because they think they're young, and they're, the feeling when you are young, which we had when we were at university, is that you're invincible. No matter what you do, no matter what you drink, you'll be fine. So I think that is the thing that you've got to challenge or deal with younger people. It doesn't matter how old you are, alcohol is still toxic to the liver. And if in fact you've got bad patterns of drinking alcohol younger, you've got a lifetime, unless you challenge those, you've got a lifetime of those bad drinking patterns, which means there's a longer period of time in which you can develop cirrhosis. It's going to impact your life and quality of life more.
And any other myths that you might hear, any other kind of odd questions that you get in clinic, like, oh, if I take a particular supplement, will that be good for me? And it will.
Yeah, these are quite common. So, people who drink heavily, they know that they need to give up alcohol, but don't want to accept that. And the part of that non-acceptance is thinking they can continue to drink the same amount, but then have a supplement that they think is going to help their liver. So patients will tell me, oh, they're having milk thistle or turmeric supplements or something that they've seen on the internet that is a liver detox. Okay. None of those things have any strong evidence that they work. And I have a rather cynical view about these kind of herbal or alternative medicines, in that if they do work, a pharmaceutical company would have found that out. They would have done a big drug trial and be making a lot of money from that. If they haven't done it, it's because it doesn't work. And people see on the internet, oh, milk thistle, or this person takes this, and they want to believe that these supplements will help the liver. But the bottom line is there's no strong evidence for it. And reducing alcohol, there is strong evidence for that.
So milk thistle, turmeric, or any of the others that you tend to get?
There's loads. There's mushroom gummies. There's various different tonics. There is this concept of detoxing the liver. Yeah. And again, we always go back to the fact that your liver is the detox machine. If you stop drinking alcohol, it detoxes itself. There's nothing that's going to make you detox your liver.
Right.
the fat that is in your liver will go when you stop drinking
Right.
alcohol. So I think that's got to be the focus rather than thinking about liver tonics or other supplements.
Any other like hot things that you get in clinic that you want us to talk about?
So zero alcohol is a huge topic at the
Okay.
moment, zero alcohol drinks. And, the zero alcohol industry is making increments in terms of the turnover in terms of billions of pounds it's generating. It's a really, really interesting topic, and we'll probably do a whole podcast on zero alcohol.
Yeah.
Zero alcohol drinks in the main are manufactured by alcohol beverage companies, and they do it as a wing of their production arm. I don't think they genuinely want people to turn their back on alcohol-containing drinks, but there is an ethical dilemma there. I guess the two questions, the dilemmas really are, can zero alcohol drinks be useful in someone who's got problematic alcohol drinking in getting them to stop?
Yeah.
And if you drink large quantities of alcohol-free or alcohol-low drinks, are you at risk of relapsing back to alcohol? And again, there's conflicting evidence for that. There was a fairly large nationwide survey, which I found really interesting, that 45% of people surveyed who drank zero alcohol drinks, it didn't change their alcohol consumption at all. And you can see what the motivation is. So, for example, if you need to be sober for something, if you've got to, look after your kids or you've got to drive, then you might drink a zero alcohol drink. Okay. And you can just sit there with your pint with your friends and pretend that you're all the same. But it doesn't change the alcohol consumption. For 45%, that's a huge quantity.
Yeah.
In about 30%, it actually helped reduce the amount of alcohol.
Right.
In about 15%, it allowed them to discontinue alcohol completely.
Right.
And in 5%, actually increased the amount of alcohol they drank. So this was really interesting about the patterns that zero alcohol is associated with. And I think for some people, in terms of anecdote and what I see in the clinic, for some people, zero alcohol really helped stop drinking. And there is certainly some small trial evidence which suggests that zero alcohol does help people stop drinking more so than soft drinks, because it's, again, the psychology of having a pint in your hand that it still thinks you're doing the same thing. But then that goes on to the next question is, are you at high risk of relapse? And again, there is some data to suggest that there was a fairly small study of about 90 patients who have alcohol-related cirrhosis, and they were undergoing transplant assessment. And the people that relapsed were the people that drank zero or low alcohol drinks rather than those that were completely abstinent.
Right.
Again, going back to the psychology of if I'm drinking something that looks like beer, then perhaps I'm more likely to go back to beer.
To it. Okay, fine. And the other challenge is that a lot of the what we call like zero alcohol drinks are quite high in sugar, for example, because they try and balance out by making them taste good or taste exactly like what they're replacing.
Yeah.
And the problem is that what they're producing might not be a healthy alternative.
Exactly. And that's the other motivation for drinking is taste. So some of the zero alcohol, low alcohol drinks may even be tastier than their alcohol containing counterparts, but some of them will have loads of sugar. And as we said, the global leading cause is the non-alcoholic fatty liver disease. It's due to diabetes, obesity. If you're consuming large quantities of sugar, you're just going to be, and you're not burning that off, you're going to be putting fat into your liver, which is then causing further risk of scarring, inflammation, and damage.
Didn't you say that you had a patient that was one of your patients for alcohol-related liver disease, and then ended up a patient because he ended up with a non-alcohol?
Yeah, so he did really well. We did really well to get him off alcohol. But then I just noticed over time his weight was climbing up, and he then said, "You know what? I'm sugar." And zero alcohol drinks was part of that.
Yeah.
So again, it's just you're moving from one vice to another vice, and it's about dealing with that underlying driver. What's making you addicted to these things? What's missing? What do you need to deal with to try and stop you getting addicted to things that are not good for you?
And that's where dealing with the triggers, dealing with your mental health is so fundamental for this.
So important. Yeah.
So let's talk a little bit about what are the earliest warning signs that people tend to ignore.
So challenging question, because often people don't get any signs or symptoms at all until you've got advanced liver disease. I guess some of the things that people might have are fatigue, poor sleep. They might feel bloated, nausea.
Yeah.
I'd say those are probably the main things, but of course they're really non-specific. So you can get them from a lot of different things.
And with sleep specifically, it tends to be that they can fall asleep okay, but then they have broken sleep through the night.
So I think it's well known that
Yeah.
alcohol interrupts your sleep,
Yeah.
your sleep patterns, the ability to get into deep sleep and REM sleep quite significantly. So yes, it might help you fall asleep, but actually maintaining that sleep quality is poor. So they might wake up, and again, they may not have awareness of this, but they might wake up several times during the night and not enter those stages of sleep which are really restorative.
Yeah, it's quite ironic, isn't it? Because a lot of people are drinking to help them sleep.
Exactly.
But then they still feel quite wrecked in the morning because of that broken sleep pattern. I think we kind of alluded to that you can be quite far along the spectrum of liver disease where you're talking about going from a normal liver to a fatty liver to having fibrosis to cirrhosis before you develop symptoms. But when do you think patients should look for advice from a medical health professional like a GP, for example?
I think if your alcohol consumption is being used as a coping mechanism, and certainly if you're drinking harmful quantities of alcohol, then again, I don't want people to just look at guidelines and say, well, that's a harmful quantity. That's not, because everyone is different. So if you feel you're getting some health related or psychological related harms from drinking alcohol and you're using it as a coping mechanism, I think you should consult a general practitioner.
I think initially, if you're finding that it's become a habit, I would probably say, see if you can break that habit yourself.
Yeah.
And if you can't, then that would be one of like the early indications of, look, I've got insight that maybe this is something that I'm dependent on.
Yeah.
And that might be one of the triggers to kind of seek help.
Yeah.
And that can be the case whether you're 16 or whether you're 60. Really.
Yeah, it makes a difference.
Yeah.
It's that psychological dependence. The other thing is physical dependence, and that you tend to get that with heavy drinkers. So if you are stopping drinking, but you're getting symptoms after that, like the shakes, people will be familiar with the term DTs, delirium tremens. That's quite a severe form of alcohol withdrawal. You get shakes, agitation, sweating. If you're getting any of those physical signs after you've taken a break from alcohol, then you definitely need to go and see a medical professional ASAP.
Yeah, because those are effectively like withdrawal symptoms of being without alcohol for a period of time. When they do approach a GP, because we tend to have people requesting specific things like, oh, I want a scan, or oh, I want some blood tests. Is that something you'd recommend?
I don't think you should go to your GP and request scans or blood tests, because they're trained to know when to do tests and when not to do tests. I think if you are concerned about your alcohol consumption, you should just go and speak to your GP. I don't think you should go there with an agenda, because the scans and the blood tests are not the be all and end all. And you can, and this is a key point, you can have normal blood tests, but yet you can have cirrhosis or advanced liver disease. The blood test can signify a problem, but people that do have significant liver disease can have normal blood tests. So you shouldn't over rely on scans. I think it's more of a global picture. And your GP or the alcohol support service or another medical professional, they are trained to try and decipher all of that and look at the bigger picture.
I normally think that in terms of speaking to any medical professional, if you talk about the problem and the signs and the symptoms that you have, rather than just that you want a particular scan, you'll actually have a better conversation with your GP and you'll get them on board, because they'll understand why you're worried, rather than somebody just comes in. Because often people do just say to us, I want a scan or I want a blood test, but they really won't go into the why. And that might be because of the stigma of alcohol, or they don't want to admit it. But the problem is that if you say that to a GP, that in this country, they will say, look, there is no such thing as a routine blood check. There's no such, because there's no reason for us to do a liver function test in a 25-year-old. But if they were to turn around and say to me, actually, I've got a family history of this, I've been drinking for the last 10 years and quite regularly, and that's the reason why I'm worried about my liver, then you might have a good dialogue, and you can talk not just about testing, but also about those support that's available for you as an individual and from a holistic point of view. So I do definitely recommend that. And we're supposed to be calm and objective always, but it can be quite difficult sometimes when you're hearing that from patients quite a lot. And it can feel like that ChatGPT has told me that you need to do this, rather than having that.
And we're getting this more and more often is ChatGPT. People come in with agendas from ChatGPT, and I get it. ChatGPT can be a useful tool, but I think you should just, as you say, you should just go in with what you're feeling and your concerns without an agenda for a particular test or otherwise.
And so, speaking a little bit about age groups, is there a particular age group that worries you the most?
I'd say twofold. We have seen over the last couple of decades, in terms of admissions, women
Yeah.
with alcohol problems really has kind of gone up. And I think women often use alcohol to self-medicate. And I'd say the group that I'm also worried about is men aged 35 to 49. There are very high rates of alcohol-related, not just liver disease, but alcohol-related brain injury, heart problems, the impact on the pancreas. And the cohort of people that we see the most in hospital are that age group, 35 to 49. And there is probably a good association with depression and anxiety. That is a group that's well known to have unrecognized depression and anxiety and a high rate of self-harm and suicide. And I think, again, alcohol being used as a coping mechanism there. So I am worried about that group.
That sounds quite extreme when you say it's a coping mechanism. But if I think about why I used to drink at university, it was specifically, I didn't think of it as social anxiety, but I was always quite anxious in a club setting, like where I was expected to dance or be in front of big groups of people I didn't know. And having one or two drinks would take the edge off that feeling.
Yeah.
And I used to just think that that's okay, that's just how I deal with the situation. But that's specifically what we're talking about, is I'm using alcohol to deal with that circumstance rather than taking a step back and saying, no, actually, maybe I have a little bit of social anxiety here, or at least in those specific circumstances. And there are more productive, healthy ways to tackle that problem, which if I knew about at the time, I should have probably done. But that's, I think, saying that you're self-medicating or saying that you're using alcohol instead of a coping strategy sounds like quite a big thing. But actually, when people look at it, it can be on quite small levels for quite what sound like innocent
and
reasons.
Very, very common.
Yeah, very, very, very common. So you mentioned the advisory role that you have. So what's different about that than what you do day to day?
So the advisory role is actually trying to look at medical student education and ensure that teaching about alcohol impacts on the body, physical and mental health is integrated into curriculums. So it's really about ensuring that the education of the new generation of healthcare professionals, the harms that alcohol could have, is part and parcel of that education process. So it will impact downstream. So when you've got new doctors coming out or other allied health professionals, they're much more aware of the harms of alcohol and how to sensitively approach it.
So you're focusing more on educating doctors or the next generation rather than from a patient point of view in that particular role.
So in that particular role, that is the major remit.
That makes a lot of sense, because every doctor goes through medical school. So if you're improving it at that level, then it means that, broadly speaking, like the level of care that people will get from all types of doctors will be better.
Yeah, exactly.
So moving on from that, if you could give one piece of advice or tell one thing to the general public, what message would that be?
It would be just take stock of how much you drink and your motivations for doing so. Try to understand, if you're drinking large quantities of alcohol, why you're doing that and how you can rectify that.
And also, if you've done that step, it might be worth thinking about what impact that is having, not just on yourself, but the people around you. So do you have a family? How is it affecting that from that point of view? Because you must also see that dynamic in play as well.
Absolutely. So, I mean, we often, people who drink heavily are drinking with someone else, like their partner. But if they aren't, then it can impact on relationships. Marriages are broken down because of alcohol. Parental responsibilities. So we have some patients who are drinking so much alcohol that they aren't able to actually effectively look after their children. And in some cases, their children are caring for their parent, which is very sad. But it can impact families. It can impact work colleagues because there are high rates of sickness and taking time off. It can cause depression and anxiety, not just in the person who's drinking heavily, but those around them. So it has a wider impact than just the actual person who's drinking heavily.
You mentioned that when we were doing a bit of discussion beforehand about the age group that you were worried about was it 35 to 49?
Yeah.
And those are specifically people that we want to be in the workforce, out working.
Yeah. So they are your kind of prime workforce. And we know that alcohol-related liver disease and alcohol-related harms in general takes those people out of the workforce. So it's a huge, I think it's one of the top causes for loss of working, life years, basically. So it has a societal impact beyond an individual.
And do you think that there's a small adjustment that you could make that would have quite a big impact into how So you're London based, for example. Like, is there something that we could do in London that would have quite a profound effect on our drinking habits, and that would knock on to improving liver-related or alcohol-related liver disease?
London is fantastic. It's got so much diversity of culture, but there's also big disparity in socioeconomic status. So you have really deprived areas just neighbouring really affluent areas. And we know that alcohol consumption is probably greatest in the lower socioeconomic groups, so the most deprived population. So addressing that balance, and perhaps that's easier said than done, I think will impact alcohol, consumption within London. Why the lower socioeconomic groups have higher alcohol consumption? Again, it's multifactorial, but I think addressing that imbalance of depravity, I think, will impact on alcohol. The other thing is a quite controversial topic, but it is minimum alcohol unit pricing.
Yeah.
So, big study in the Lancet a while ago about Scotland, where they have established minimum alcohol unit pricing, 50p per unit there back then. It's making alcohol harder to access at a population level. And in Scotland, there is now evidence to suggest that there is a reduction in mortality and a reduction in admissions due to alcohol-related liver disease as a consequence of this public health policy. England, Wales, and Northern Ireland haven't followed suit as yet. And there's, again, a lot of discussion around whether we should be doing that.
Right. Well, you were talking about how fantastic results they've got specifically in Glasgow, and how the mortality rate has been significantly changed.
Yeah, so the life expectancy in Glasgow, I can't quote the exact number, but the life expectancy in Glasgow is really quite poor. And that is a combination of, again, low socioeconomic status, high rates of alcohol and drug use. And things have gotten better, a lot better. And maybe minimum alcohol unit pricing is part of that. But certainly there's been a lot of investment in terms of alcohol support services, alcohol care teams within Glasgow that's really improved things a lot. And I think it is a model for change that we can apply to different parts. It was significantly low in Glasgow, so I guess there's greater capacity for change. And I think it is an example of how we can change things. If you address every little aspect of how we deal with this, we can make an impact.
With regards to stigma,
yeah,
is that one of the biggest takeaways that you would say you'd want people to take away from this kind of discussion?
Stigma is a major barrier. It stops people confronting their own alcohol consumption. It stops people accessing community alcohol support services or seeing their GP. And the problem with stigma is that you're just allowing habits, behaviors, alcohol consumption to continue unchallenged, and you might get to a point of no return. So I think it's really important to dispel the stigma in alcohol. I think you need to be honest with yourself and go and understand that the people you go to speak to, medical professionals, people in alcohol support services, they are very used to talking about alcohol, and you're certainly not the old school kind of mentality of ticking someone off because they're drinking alcohol too much. You won't experience that, or you certainly shouldn't experience that. The person you go to see should be understanding. They should be holistic. They should try and explore why you're drinking and the drivers for you to drink, and other factors like anxiety and depression. So I think you should not be worried about addressing this early. That's the best time to do it, because I think the person you're going to speak to will be a sympathetic ear and will really help you.
Well, I think it's been really useful. Thank you so much for coming and talking about it.
Thank you. Thanks for having me here.
Yeah, it's a pleasure. We should do it again.
Yeah, we should.
We'll talk about other topics that are kind of in the back of your mind that you might.
Okay, great, fantastic.
We can do something like that.
Yeah, that'd be great.